Hello, my name's Ian Davis. I'm Chair of ANZUP Cancer Trials Group, and I'm here at the annual scientific meeting in Adelaide with Professor Michael Hofman. Good to see you, Michael.
Always good to see you, Ian.
We've had an interesting time. We had our first international trip for some time, going to the American Society of Clinical Oncology meeting in Chicago in June, and we had a couple of presentations presented in the same oral abstract session.
Yes, it was quite extraordinary. There was the oral GU session, predominantly prostate cancer dominated, and two presentations from the ANZUP Cancer Trials Groups, and two really different presentations, one on the TheraP trial using lutetium PSMA, my area, and one using enzalutamide, the ENZAMET trial, which is your baby.
Isn't it lucky we're both here to talk about
I
this?
know.
So can you tell us a little bit about TheraP and what was the new information that you presented at ASCO?
So TheraP is the first randomized controlled trial of lutetium PSMA 617 conducted anywhere in the world. It's a phase 2 trial run at 11 sites around Australia, 200 patients randomized to either lutetium PSMA or carbazitaxel chemotherapy. And lutetium, it's a new radioactive drug, so we administer it intravenously, travels around the circulation, binds to prostate cancer cells, and it's a really novel way to deliver high doses of radiation to sites of prostate cancer wherever they are in the body, so for treating metastatic disease. And this trial was conceived at a ANZUP Concept Works shop back in 2015-16, back at a time when no one had heard of this treatment. And I was really fortunate to become chair of that trial and have the support of you and the whole ANZUP machinery to turn that trial into a reality. And it was quite a complex trial, the logistics being quite complicated. Lutetium delivered from ASCO, manufactured in hospital radiopharmacies, given to patients. And in Chicago, we reported the 3-year follow-up.
So what were the initial findings and what were the updated findings this year?
So in the initial findings, the study met its primary endpoint. We showed a PSA response rate of 66%. That's a reduction in 50% or more in the group of men randomized to lutetium, compared to only half that in the group randomized to carbazitaxel. But the efficacy went beyond just a biochemical response with PSA. We showed that progression-free survival by radiography, CT and bone scan, was prolonged. There were much less side effects, less grade 3, 4 toxicities with lutetium, the targeted treatment compared to chemotherapy. And I think maybe even most importantly, the patient-reported outcomes strongly favoured lutetium PSMA 617. That was mainly because we don't get the chemotherapy-related side effects with lutetium, and it's also very effective at controlling bone pain, which is a common symptom when the cancer spreads to bone. So we sort of met all of those, and then the one that was waiting was overall survival, which needed longer follow-up, and that was really the reason for the updated presentation at ASCO.
And what did you find?
We did not show an improvement in overall survival with lutetium PSMA. Overall survival is a much tougher endpoint. It depends not only on the treatment, but what happens after the treatment. And lutetium PSMA is available off trial in Australia during the time we conducted the trial, so patients could go off and pay for the lutetium therapy, and around 20% who had carbazitaxel did that. Also, there was a significant dropout rate in the carbazitaxel arm. Patients, being an open label trial, knew if they were randomized to chemotherapy or radiation, and some patients wanted the novel radioactive treatment, and when they were randomized to carbazitaxel, they dropped out, and we did an intention to treat analysis. If those patients went off to access lutetium, they were analysed as if they had carbazitaxel. So due to high, not an insignificant dropout rate, around 15% after randomization, only in the carbazitaxel arm, and post-protocol availability of lutetium, really makes overall survival hard to assess. But I think when we look at everything together, it is a, although a phase 2 trial, I think it is a practice-changing phase 2 trial because it complements the industry trial, which is the VISION trial. The VISION trial provides the overall survival data, and it's unequivocal. It shows that it can improve overall survival. And now TheraP provides really strong data in patients where you're thinking about, should I use carbazitaxel, should I use lutetium? I think there are enough primary and secondary endpoints pointing in the direction of better outcomes and patient outcomes with lutetium, and I think that influences practice around the world.
So I've heard a couple of interesting interpretations about the carbazitaxel. Some people have looked at the survival data and said, oh, carbazitaxel is just as good as lutetium PSMA. And others have looked at the early results and said, oh, carbazitaxel is a terrible drug, no one should ever use it. how do you think people should be thinking about these two agents in approaching patients with this disease?
I think the best analogy I can give, I'll give a medical oncology analogy, even though I'm a nuclear medicine specialist. I think when enzalutamide or abiraterone came around in the hormone-sensitive space, the early results showed that it was comparable to docetaxel in terms of survival. But the side effect profile and patient tolerance was very different. People didn't want to lose their hair, they didn't want peripheral neuropathy, they didn't want diarrhea, the whole range of side effects. And it was very clear that abiraterone and enzalutamide was much better tolerated, and there was a big drop in quality of life initially with chemotherapy that then recovers. But patients don't want that loss in quality of life. I think if we take the crossover out of it and we just accept the raw results, which is there's no difference in overall survival, we still have a new treatment that is much better tolerated with less side effects. And that's what patients will want. They'll want the treatment that's much better tolerated, particularly even more relevant in this group of patients who have 12 to 18 months to live. You can extend that to 15 to 18 months with these new treatments on average. Some patients live much longer. You want to have quality of life. You don't want to be admitted to hospital with febrile neutropenia. You want to be staying at home. You want to be pain-free.
So we've got a new treatment option, but the old treatment options are still there, and they're still appropriate for some people in certain conditions. So
and you're still going to use
options.
it. So that's the other way to interpret it is it's a new treatment option. It's not going to replace carbazitaxel. And you could use that analogy in the castration, in the hormone-sensitive space as well. The docetaxel didn't replace Abienza. You may now give Abienza first if it's available, and then give docetaxel subsequently. So it's how you sequence, and that's going to depend on availability. I think it's also worth mentioning there's this group of patients that we see in the therapy study. It's a small group. It's sort of 10 to 15% that I think we lose when we talk about averages. We lose them on the Kaplan-Meier, that there's a small group of patients who really have quite deep, extraordinary and prolonged responses to lutetium PSMA. These are patients, and we see them in our clinical care, and you can't tease them out when you just look at the statistics, but they come along in severe pain with a PSA doubling time of 1 month and fatigue and loss of weight, and you look at the patient and you go, you've got 2 to 3 months to live, yet 4.5 years after lutetium, they're still alive. It might only be the 1 in 10 patients, but there's these group of patients that are exquisitely sensitive to lutetium PSMA, and if you're lucky enough to be one of those, it can be a really life-changing treatment. And we presented some data earlier in the year in ASCO GU suggesting that PSMA PET as a biomarker, the patients that have very high PSMA expression are the patients that are more likely to have these more exceptional responses.
So you might be able to stream this treatment more appropriately to people most likely to benefit.
Correct. Now I think we should change topics and flip, because following my talk at ASCO, you did a huge talk on ENZAMET, also with long-term follow-up as the theme. What did you find in the longer-term follow-up with ENZAMET?
Yeah, well, so the last time we were at ASCO was in 2019 when we presented the results of the interim analysis. So ENZAMET was a very simple concept. It was taking a drug, enzalutamide, that's used in castrate-resistant prostate cancer and moving it earlier in the treatment course to say, can we improve overall survival by adding it to treatment in patients starting hormone therapy, testosterone suppression, with hormone-sensitive prostate cancer. What we found from the interim analysis was that there was an improvement in overall survival for patients allocated to receive enzalutamide with a hazard ratio of 0.67. And the landmark analysis at 3 years showed that 72% of men were still alive on the control arm, which was an active arm, compared to 80% on enzalutamide. So that was a lot of interest. Now we come back with the results of the planned 470 events analysis. The previous one was after half that many events, and a median 68 months of follow-up. And what was shown is that survival benefit has been sustained right out to now well over 5 years, with a 5-year difference in survival of 57% compared to 67%. So that benefit is sustained.
And did you look at any subgroups within that? Were there particular patients that benefited more than others?
Yeah, so we did some exploratory analysis to see if we could draw that sort of information out. And a couple of things came out of that fairly clearly. Firstly, if a patient is well enough to receive additional therapy, then androgen deprivation therapy alone is not enough. We should add something. The second point that came out was that as far as we could tell, there didn't seem to be a lot of difference for patients receiving either enzalutamide or docetaxel or the combination of those two. The survival seemed to be very similar, with the possible exception of the patients in the worst prognostic group, those patients with high volume disease that had been diagnosed at the time of the initial diagnosis. So that group is destined to do less well, but we seem to be able to get better outcomes with the triplet therapy there. But otherwise, it looks like we're seeing similar benefits across the board.
So it sounds like there's compelling data in favour of enzalutamide in that earlier setting. But if you're a patient out there, this treatment's still not reimbursed in Australia, is that correct?
So as we're speaking in July 2022, it's approved in Australia but not yet reimbursed for that indication. So we're hoping that that situation is going to change. There are some other similar agents that are under consideration by PBAC, so we're hoping that one or more of those will become available for people soon. In the meantime, there are still ongoing clinical trials in this area, and people in that situation should be talking to their treating doctors and asking that question: is there a clinical trial that might be suitable for me?
And this is a challenge with lutetium PSMA as well. We now have the strong evidence base from several trials, but it's still not reimbursed by the Medicare system. So accessibility for the patients is still challenging.
Yeah. Well, look, thanks, Michael. Great to talk to you. Fantastic to have built this relationship between yet more disciplines within ANZUP and nuclear medicine now firmly within the fold. So thanks for talking with us today.
Wonderful. Thanks for the opportunity.